Is everyone good? Are we good? Um, hi everyone. Pleasure to be here this morning. I'm going to actually take a point of personal privilege, if I can, as a presenter, and just thank the organizers in MHCDS. When I was a student in the program, I benefited so much and was so inspired by everyone at the front lines of healthcare and hearing about what you do every day. And I think this symposium over the last day and a half has really sort of re-energized me and inspired me into what you all do, and I'm really appreciative of MHCDS to provide the opportunity that they do for us to come together and continue those discussions that we did in the classroom. So thank you to all of you all for being here. Thanks for the discussion, and thanks for what you guys do every day. Julie and I are tasked with giving a state and federal policy update and giving you some tips on how to influence policy in 45 minutes. So this is a big task. What is nice is I think previous speakers have laid the groundwork really nicely for us. We've heard policy come up many, many times throughout the day and a half. And Catherine this morning, I think, really gave an effective call to action for you all in the voice that you can have in the policy process. So we're going to try in the next 45 minutes to give you a little bit of the nuts and bolts of policy and the process and how maybe to influence policy. I want to make a caveat that there are a lot of policy people here now. I think when I started the program there were less, and now there are more. So there are a number of us that are working in the policy world. So there's lots of collective expertise in this room. So when I mess up, please you all let us know where we made the mistakes and chime in with your voices on this. So we'll talk about also federal policy issues to watch, especially maybe as it relates to social determinants of health, and then also at the federal level and at the state level, and hopefully lots of times for questions. So let me just go back to something that Catherine Pitt said this morning on the empowerment of your voice and how it matters. The Gallup poll does a survey every year on the most trusted professions by the public. The top five include number one, nurses, and within the top five are clinicians, physicians specifically. The lowest in this survey for the lawyers, lobbyists, and others, and policymakers in the room, elected officials, we rank down along the used car salesman level on the public survey. So it says the registered lobbyist. Yes. So I say that with you. As someone that's in that lower end, I hope you still listen and trust me, but really, really, your voice matters. And when we're thinking about the social determinants of health, and people trust you in the public domain, when we're thinking about social determinants of health and what we've heard today or the last couple of days and what you're going to do in your local communities and how you're going to advocate on this issues of health equity and social determinants of health, you need to first realize that the policy is created at lots of levels. Given sort of an overview of what kinds of things are thought about at each level of government, but I want to really emphasize to you the institutional and professional societies, especially for you all, the clinicians in the room. I have a similar situation from Catherine. When I did the MHCDS program, I was working for a senator. I was in the classroom, and some of the physicians in my study group were saying things to me about, at the time, it was scope of practice. And I remember thinking, wait a minute, your lobbyist was in my office in DC, or my boss's office, our office, last week. That is not at all what your lobbyist was saying to me, that you pay your professional dues to, that is now representing you to my boss, to the person that's going to be voting on these issues. You have a lot of influence in those societies, in those professional societies. They have advocacy committees. They create policy guidelines. You can join that. You can put at the very basic institutional and professional society level, you can have your voice heard, and please exercise that. It's important. The second, this is not like, I'm not going to go through how a bill becomes a law, but I trust you made it through junior year of high school. We can do that sometime. It is not what you learned in junior high. But I did want to say, when you're thinking from the advocacy perspective, also what Catherine mentioned this morning, there's lots of different levels that are making policy, and you can influence most of them, all of them, particularly the executive branch and the legislative branch. We'll talk about that. And then again, this is where we sort of depart from our junior year of high school civics class. There is a policy process in this area, in both domains, in the legislative and the executive branches, as they consider policy. And it's important to understand that, to be able to influence it. I want to, as we talk about social determinants of health, I think the local and states are doing a better job beginning to form policy and adopt policy for social determinants of health. The federal government's far behind it. And that's still trying to get it on, the ideas of social determinants of health and health equity on the agenda, and what that policy will be. What does it look like? There's lots of studies out there, people are doing work, but there's not anyone coalescing over what our policy direction is at this point with solid legislative or regulatory guidance. So with that said, I'm going to just talk a little bit about where. So that's where we are in like level setting, policy. We're going to dive now in with the lens of social determinants of health on what I'm going to offer is what's happening at the federal level, and then I've got 3 issues to watch that may happen at the federal level or will be discussed at the federal level. And probably what would be helpful is, as you think through the last day and a half, where could your voice be heard as it relates to the issues that we've been grappling with on equity and social determinants of health. So for the first time, to that end, Alex Azar, Secretary of HHS, also a Dartmouth grad, said for the first time in November, had a speech in which he started giving some indication about the administration's perspective on social determinants of health. In that speech, he said 2 things. CMMI, the Center for Medicare and Medicaid Innovation, sometimes we call it the Innovation Center, will start looking at a whole model, a whole person model. We have yet to see what that looks like, but he says that's forthcoming. He also said at this speech that Medicaid could start reimbursing for some social determinants of health, particularly in the speech he said housing and nutrition. Julie will talk a bit about what the states are doing in that Medicaid space. We've seen a little bit of other action in the federal government on social determinants of health. The last bill that was passed in 2016, as President Obama left office, was the 21st Century Cure Act. It did a lot of things. One small provision in it was socioeconomic status, risk adjustment on some of our quality measures. So I view that as the federal government tipping its toe into sort of this space, or the toe in the water. Also in 2018, Medicare Advantage put out in some regulations, not legislation, again, making sure we make those distinctions in policy. Medicare Advantage said that they will begin on supplemental plans to reimburse for some social determinants of health. So we see that. We also see CDC, NIH, AHRQ, HAMSAMSA, all of those public health agencies that we think of public health and research, we see them doing more work and research in social determinants of health and health equity. That's going to be important in a future slide, so just remember that. And then in Medicare fee-for-service, we see very little. The National Academy of Medicine has put out a report. The MedPAC is the commission, Medicare Payment Advisory Committee. They've also written some chapters on social determinants of health, but nothing's moved yet in that space. So with that, so I've sort of given you now, there's the policy process, there is where we are in social determinants of health. 3 issues at the federal level I think it's worthwhile to watch and think about how you might be able to use your voice. And I'm giving you 3 of many. The first is the 2020 budget, so I'm giving you one that has to be dealt with, must-pass legislation. We love must-pass legislation in Washington because it means it's a vehicle. Sometimes you hear it in the news as a Christmas tree. It's something that you can attach. It's moving, so there are opportunities to attach other policy principles to. Second is surprise billing. This is a maybe, might pass, bipartisan interest on both sides of the Hill, House and Senate. They're talking about it, the press is talking about it, something that may impact many of you in this room, so we'll talk about that really quickly. And the third is Medicare, and that's because, as we heard from our first beginning opening, it will be discussed. It's a presidential year, it will be discussed. And I'm going to go through these pretty quickly, so I'm happy to take questions on any of them to begin with. So I'm going to start with the pressures policymakers face. And it comes down often to money. Policy, politics, the rubber hits the road when it's how are you going to pay for it and at what cost? What are you going to trade off? Or are you going to just find new money? Also a contentious discussion. So last April, CBO, Congressional Budget Office, are what folks in Washington look to as the scorekeeper, put out a report they do every year. They said these outlays do not keep up with revenue, okay, for the federal budget, and by 2020, our deficit will reach $1 trillion by 2020, 2 years earlier than they had thought the previous year. They also said on the right that the federal debt held by the public is currently at about 86%. They warned that it's going to be 96% by 2028 on their estimations, and that's the highest amount since World War II. I mention that because part of this must-pass legislation is that Congress sets the limit by which we can go up against the debt ceiling. We're at 22, and as of March 22nd, we were at $12 trillion. We are now, as a federal government, using extraordinary measures. Those extraordinary measures will end at the end of this fall, so Congress has to act to raise this debt limit. It's happened many, many times. It's happened on Republican and Democrat administrations. There's always a question for those of us that worry about health and anything in the country is, what will the politics be around it, and will they want to pay for this raise of the debt? If policymakers start looking to pay for it, the question is how. So with that, the other piece of the budgeting issue is this question of appropriations. Now, federal budget is divided into two parts: mandatory spending, discretionary spending. Mandatory spending, eligibility, no cap. If you're eligible for those programs, you get on. So you'll see that in the blue on this pie chart. Medicare, Social Security, Medicaid, they drive our mandatory spend. It's about 2/3 of the federal budget. 1/3 is discretionary, generally divided half between defense and non-defense funding. Non-defense funding gets broken up further. Our public health is in that little sliver. That's where our NIH, that's all those research public health agencies are funded. When the government shuts down, that's what you're talking about. You're talking about that pie, that little 1/3 piece of the pie that Congress has been unable to come to an agreement on. And that's important because Congress has to deal with something huge this year. That debt limit was the first one. The second is what you'll hear on the news as budget caps. In 2011, Congress passed a budget deal. They said, we're going to set some caps on what you can spend as the country, as the appropriators can. And if you don't, later on that year, 2011, policymakers find $1.2 trillion of deficit savings. You will have sequester. So automatic sequester will be triggered. In 2011, they were unable to reach agreement. Sequester happened. That's the yellow line. Every year, Congress has voted to go above, to budget higher than the sequester caps. 2019 was the last piece of legislation to raise those caps. If Congress doesn't act, we see a big cut in that discretionary pie. So in the non-defense and defense discretionary that we just discussed. So there's our must-pass legislation, the debt limit and Congress dealing with appropriations for FY20. The question is, what happened with those budget caps? The question for you all as potential advocates are, what happens if that cut happens? What happens to your NIH research? What happens to your ARC research? What happens to the public health programs that you care about in your community that may be outside, helping your patients outside the realm of the actual care of delivery that you're giving in your institution or in your clinic? So the second issue I want to talk about is the may happen bucket, and may happen because very little actually happens in Washington, just lots gets discussed. But because surprise billing and transparency. Surprise billing sort of defined as when a contracted hospital has a hospital in network has a non-network provider somehow contracted with them. often in the news, happening in the ED. You can see it in the news also with some other radiology, anesthesiology, those sorts of programs. It has been the topic. You've probably seen NPR and Kaiser Health News is doing a bill of the month. They're going in and they're finding someone that has a really high medical bill and looking at why and trying to understand that. The media's influence in this has gotten policymakers' attention, both the White House and the Hill. As I mentioned, there was a hearing last week. There was legislation introduced by our senators from New Hampshire also on this topic as well. So that's one issue that's going on in sort of this private market. The other issue is around health literacy, and not surprise bills, but bills higher than people expect to get. And that's because of what you see as the employer-sponsored plan, which is where most people in the private market get their insurance still. Employers are moving from traditional plans to high-deductible plans. That's putting patients, more onus on the patients to understand where they're coming from, giving them opportunity to shop a bit, but also being more reliant or understanding more about what their costs are as they hit their high deductible. So you have these two things happening. You have this media issue, you've got this question around health literacy and people understanding what it is about their insurance, and it's causing policymakers to act. This map is on surprise billing, and you can see it's EDs, in and out of network physicians. But we're seeing states act and balance billing laws. We're seeing federal rulemaking on transparency. Anyone that works for a hospital is now publishing your essentially charge master publicly so people can see, but in a machine readable, easy format. Lots of executive work going on there. And then we see federal legislation on the surprise billing, the questions that they're grappling with and the policymakers. And in a fun MHCDS plug, some of the leaders of this is one of the staffers working on it is a current MHDS student. So you're seeing policymakers grapple with what are the out-of-network rates, how should they settle these bills, what's the responsibility of provider and insurance on notice and disclosure, and then also what's dispute resolution. And this is my last piece. This is Medicare. We've already talked about Medicare. So this is not probably see huge, well, with also great to have an MHCDS alum that's working with Senator Sanders, who's a big voice in this space too. Not sure in an election year, to be frank, there's going to be much action on Medicare on Capitol Hill, though it will be discussed a ton in the election. We're already seeing it in the election with the presidentials a lot. So we've already talked about, it's a huge portion of our budget. The Medicare trustees last year said actually it's going to be Part A, the trust fund, the hospital portion will be insolvent by 2026. That was also 3 years earlier than they had said the year before. So we have a little bit of a looming crisis. Congress has also never let it go insolvent, so don't worry about your future and your parents' future. But Medicare enrollment is growing significantly. Every day, baby boomers are aging into Medicare. 10,000 people a day are coming onto federal rolls. That's a lot. And that's a lot for those of you that take care of folks. That's a lot for all of us as taxpayers that help pay for the program. So what are policymakers going to do, right? They've got a couple choices. They're going to cut providers or beneficiaries. That's hard. Catherine said there's lobbies on both ends, senior lobbies, provider lobbies, electoral pressures. There's also potential reforms. This makes all of us from MHCDS really excited, right? It's everything we know about potential Medicare reform and alternative payment models. HHS does put out a report every year indicating where the federal government is on tying Medicare payment to quality and value. Our goal under Secretary Burwell set a goal under President Obama that we'd be 50% by 2018. This report actually said we are making movement towards it, but we're still only at 34% of our fee-for-service. So then we began this discussion. There's also a conversation about, do we redo Medicare totally? And just really carefully, Catherine can answer any questions about the intricacies of Medicare for All. We see a House bill, we have it sounded this morning, breaking news, an imminent Senate bill coming. There will be hearings in the House in 2 committees, Budget Committee and Rules Committee, likely. And I just wanted to make a quick, just distinguish one thing really quickly. We have the single payer, the Medicare for All, of which we have an expert in the room. There's also this public option idea too. One is a Medicare X plan. This is a Bennett-Kane bill in the Senate. It would allow for a public option buy-in for folks to choose alongside private insurance. There's also Medicaid buy-ins going on as a public option in states that Julie will talk about. So I'm going to turn it over to Julie. Before I did, I just wanted to make sure folks realize, I just chose 3. I chose 3 things that have impact on social determinants of health that you could use your voice for. There's a whole host of other things that we can talk about at any time at coffee or at Pine. But I did want to say one thing. Every year, the federal government puts, for folks in the room that care about healthcare, the legislation is legislation. We can talk about how to influence that. It's this regulatory space that your technical help, your subject matter expertise really, really can be impactful. It can be impactful to your trade groups. It can be impactful to state lawmakers. Every year, payment rules come out: outpatient payment, inpatient payment, physician fee schedule, the quality physician payment program. MACRA, we've got a MACRA expert here, a MIPS, all of those things that folks care about, the acronyms of Washington. There is a law that governs how these processes get rolled out, the Administrative Procedure Act. It gives citizens the right to write into the federal government and offer their opinion, and it requires the federal government to respond in the rule, in the Federal Register, in those little columns that are really, really hard to read. But you can do it. There is opportunity, and there are people like me, like Sean, like Dina, people that are working for associations that are looking, or entities that are looking for that help of the subject matter expertise that you provide to try to help articulate to policymakers what it is that matters at the front line. So with that, I will turn it over.
Hi, everyone. So glad that you're here. I'm Julie Barton, and just for a little framing, I spent a couple years working in policy for Mass Health, which is the Medicaid agency in Massachusetts. I now have moved into a legal role, so those big policy ideas that people have, I now am sort of saying, oh, that doesn't quite work because of what CMS says or whatever. But I have, I think, a pretty good perspective on how we think about policy making and sort of what the challenges are. I'm going to start just sort of level setting for the group about Medicaid and just reminding all of us that we do cover, Medicaid covers 1 in 5 Americans. We provide assistance to 10 million Medicare beneficiaries through the Duals program. We also cover a lot of long-term services and supports, a lot of long-term care financing. And then with respect to safety net hospitals, we are a major source of revenue for those hospitals. And then lastly, which I think is important, we sort of will get to more of this later, is that those dollars have been, in some cases, in some states, not in all, the opportunity to sort of try to innovate with respect to healthcare, try something new. And so I think it's important to kind of recognize the role that Medicaid plays beyond kind of thinking about it as, safety net only. It really does, at least in our state, is driving a fair amount of thinking about how we structure healthcare. So another level setting, just to point out sort of where we are with respect to Medicaid growth, which is fairly flat, and then Medicaid spending on the federal side, you can see it's sort of projected to be going up in fiscal 2019, which fiscal 2019 is almost over, so this kind of, I'm not sure how this played out, but these were the projections. And then state Medicaid spending looks to be going down in 19, although as I understand it from other data that I've seen, state revenues generally are predicted to be a little bit lower. So, those two things may mean that states aren't seeing a lot of sort of benefit of these costs going down. And then a reminder too about where Medicaid expansion is these days. We've got 36 states plus DC have adopted Medicaid expansion, leaving 14 states that have not, one of which is North Carolina, which I'm going to talk about later in a social determinants of health arena, but just pointing out that the sort of legacy of the ACA or the continuation of the ACA is making its way, but there's still many, many states and many, many Americans that are not, that don't have access to Medicaid because their states haven't expanded. So with respect to state trends, I think sort of one of the themes is that there's an effort to respond to federal uncertainty. So as Allison alluded to, there have been many ways in which at the federal level, there's not a lot of guidance on sort of how we're moving forward. We have lawsuits that challenge different policies. We have HHS decisions that are, threatening to the health of many people. So I think states are themselves thinking and working on different policies that will maybe mitigate a bit of that uncertainty. And so I think that those include, so for example, with efforts to stabilize state insurance markets, we've got individual mandates in 4 states. We've got states that have gotten approvals for what are called Section 1332 innovation waivers, but that allows them to have a reinsurance sort of underlying their insurer's sort of financial situation. We've also got consumer protection laws that are kind of aimed at sort of, for better or for worse, being reactive to the fact that these short-term and these health plans that have now been allowed to sort of protect consumers that are using those. Then Medicaid expansion, as I referred to, prescription drug costs. I mean, obviously there's so much going on in this space, but I was struck by a statistic that in 2018, in 42 states, there were 160 odd bills introduced to try to deal with prescription drug costs. So the federal government's working on it to the degree that it can, and we sort of hear about it, but also states themselves are trying to take it on. And we just heard in Massachusetts about our governor who's, pushing and going to try to push anyway a pretty significant prescription drug effort. And I think this is happening sort of across the country. And then the last point is Medicaid buy-in. And someone asked about, the idea of Medicaid for all versus Medicare for all. And I think, the point that Catherine made, which I think is a good one, that there is the problem of, sort of silos with respect to expansion like that, because one state has it, the neighboring state doesn't. That doesn't really get everyone where they need to be. But I think with respect to the states that are looking at it, for example, in Massachusetts, what we've done is we've said, you can buy into Mass Health, into Medicaid, employers can buy in, and then have to, there are restrictions around how that works for them and what they have to contribute, but it is something that some states are looking at and studying, and some have legislation. The next piece I want to talk about is Section 1115 waivers, and it's like so wonky to talk about like the actual statute and the waivers, but those are essentially ways in which states can innovate beyond what they've agreed to at some point with respect to what's called their state plan. And so within Section 1115 waivers, I wanted to just focus on the Medicaid work requirement issue, which has been prevalent in the news and sort of, from my point of view, scary. I'll say that. I have the luxury of working in Massachusetts where I don't think this would come up, but, in other states it has. And then also just to sort of go from the top of the funnel down to Massachusetts specifically about some work we're doing on social determinants of health through our Section 1115 waiver. So Medicaid work requirements, you can see that there are, not 4 states with approved waivers that allow for it, and then some pending states. But, recent news includes the fact that the DC District Court, DC District Court vacated the Secretary Azar's, HHS's approval of the Kentucky work requirements and the waiver itself. And that waiver, honestly, includes premiums It includes coverage lockout for not paying your premiums, and it includes work requirements. So premiums for folks whose income is at 133% of the federal poverty level, or at 100%. I mean, asking them to pay in for their insurance. So that was struck down, and I think what the court's point was, you know, the sort of standard for administrative, for saying no to administrative decisions like this is arbitrary and capricious. And the court found that they just hadn't taken a look at what it would really mean for the delivery of health care for low-income folks, and that that's what the statute requires, and that they hadn't actually really thought about that, was the way the judge kind of stated it. Arkansas's waiver was also struck down by the same judge. At the same time, HHS recently approved Utah's partial waiver that includes work requirements. So there's sort of like a push me, pull you, you know, there's a lot going on in that space. And I think, kind of to Allison's point, like the judiciary may be a place where we end up seeing some of this playing out in a way that, for better or for worse, you know, sort of changes how people can actually have a part in these processes. And then some New Hampshire Medicaid members recently filed a suit in the last couple weeks challenging New Hampshire. So obviously a lot coming, and we'll have to see sort of, you know, how it all plays out, but this is something that I think it's worth keeping our eyes on. I wanted to now, just switching to Massachusetts, I can't help but talk about it. So sort of back to Allison's point, these are all the different, or some, let me put it differently, of the stakeholders that were involved in our healthcare reform. And we had 2 years of listening sessions. We talked to a lot of folks, heard from a lot of folks. It's sort of the upper left corner is about the community advocates and those that participated, you know, sort of advocating on behalf of members. And then we have provider payers, the systems, the hospital systems, our community health centers, community mental health centers. Government clearly had a big role to play in this reform. So I just wanted to remind us, if you are someone, and I know there are stakeholders in this room that are part of our ACOs, or you know, these are ways that you can participate through your organization. And we can talk more about that if you want. We have work groups. We procure folks to come and give us information. We have requests for information. We do a lot of sort of listening. And we're still listening about our program that I'm going to get to that's about social determinants of health. But let me just give you a background. So again, I can't help but talk about Massachusetts given my role. Hopefully I'm not going too far over time. So we have 17 ACOs now in Massachusetts. We have 3 different models. Those ACOs cover about 900,000 people. And I know you heard from Christina Severin, who's the CEO of one of our ACOs yesterday. And her model is fabulous. It's a community health center based model. It's unique to, we do not have another ACO that is structured in the way that hers is. And you know, really looking forward to kind of seeing how that works, because it's not hospital-based in any way. And again, it's all community health centers. But and our ACOs are financially accountable for specific quality measures, which include managing chronic diseases, screening for BH conditions, and then follow-up treatment. Again, follow-up treatment after medical or behavioral health hospitalization. We want to keep our folks with disabilities living in the community as much as possible. And we're looking to reduce preventable emergency department visits and hospitalizations. Not on this slide is the fact that we require our ACOs to screen for what we call health-related social needs, social determinants of health. So that is another aspect of our quality program that frankly has implications for how the ACOs are going to be paid. So we've tied them pretty tightly. And then you can see too, we're going to look at member experience surveys. So one part about Mass Health reform that I wanted to talk about that I think has been thought about as a social determinants of health effort. Just wanted to give you a quick point of view about that. This is our community partners. We have 27 community-based organizations that we've procured, that we are partnered with, we are paying, who are then themselves partnered with our ACOs. And their role is to provide care coordination and support, care management for folks with high-need BH concerns, and then for folks with long-term services and supports needs. And so far, we've identified about 45,000 members that our CPs, as we call them, are working with. Again, through partnerships with the ACOs. It's when you talk about sort of what you might miss in an innovation, and honestly, in my experience, we could never have thought of everything, and when we were putting this program together. So I will put that out there. It does seem pretty hard to be able to do that. And then CPs are paid to engage these members and then work with the healthcare system to coordinate and improve their care. Okay, so Massachusetts has, as part of its most recently updated Section 1115 waiver, we have money that I think Christina Severin, again from C3, talked about, $149 million that's dedicated to providing what we call flexible services. And those and the way we worked it out with CMS, and that took a while, frankly, to put together with CMS what we call a protocol that allows the expenditure and federal match on the funding that we are using for these services. So there are going to be housing supports, tenancy sustaining, pre-tenancy supports, and nutrition supports. So I think, Catherine, you said something about how do we get people to get more nutritious food. Well, what we're hoping to see in these programs our ACOs will develop is a food pantry or farmers or vouchers for food at a grocery store, that kind of thing. So our program has, all of these programs that have just been sort of approved by CMS have relationships to home and community-based services waivers, but generally our members need to have a needs-based criteria, they need to demonstrate, and then they need to demonstrate a risk factor related to homelessness or food security. Our ACOs will receive the money ahead of time and in a PMPM form, and then they will contract with social service organizations to provide these supports, or if they are able to provide them in-house. We have some of our ACOs already have a food bank or a food pantry, for example. So that's sort of still in development. As I said, those are the supports we're offering, and we will launch in 2020. And then I just wanted to point out that another state recently got approved, very recently got their sort of SDOH waiver approved. And this is their waiver that transitions them to managed care, and theirs will involve housing, transportation, food. This is North Carolina, sorry for anyone in the room from, and interpersonal safety. And so essentially members that are enrolled in one of their managed care organizations in certain regions will have access to these kinds of supports. And they also have what I think is an interesting construct where lead pilot entities will be sort of the almost hubs for the delivery of these services and the payment of these services. And so I think, again, just like in Massachusetts, it remains to be seen how effective these programs are and sort of the use of the money, how well it works. But I wanted to point out one thing that I think is the reason I chose North Carolina, because there are a couple other states with waivers that allow to pay for housing, food, that kind of thing, is that, as I noted on the expansion slide, North Carolina is not an expansion state, but here they're entering managed care with this waiver with social determinants of health kind of at the forefront. It's what people are talking about with respect to their waiver. So it kind of shows you that there's more thinking about this now, and in different states are really pushing it. Massachusetts has had managed care for years. We're just getting to this, because again, I think maybe the time is right. I mean, I hope it is. So I just thought that was interesting.